Okay, good morning, everybody. I'd like to start this session. The title of this session is of COVID-19 in Japan. This program, this session is programmed by Japanese Society for Chemotherapy. I am the chair, Professor Tetsuya Matsumoto. I am the president of the Japanese Society for Chemotherapy. So in this session, we have chapters related to COVID-19. So the first speaker is Professor Satoshi Takahashi. So I'd like to introduce Professor Takahashi. He's the professor of Department of Infection Control and Laboratory Medicine, Sapporo Medical University School of Medicine. His main field is urology, and also he is the expert of the infection control, laboratory diagnosis, and antimicrobial resistance, of course, COVID-19. So his title is Control of 2020 Coronavirus Pandemic, including Antigen Testing. So please start, Professor Takahashi, your lecture.
Okay, thank you very much for Professor Matsumoto. So I am Satoshi Takahashi, Sapporo Medical University. So I engaged in infection control and laboratory medicine. So I'd like to share my slide with you. Can you see it?
Yes.
Okay, thank you very much. So my title is Control of 2020 Coronavirus Pandemic, including Antigen Testing. So this is my COI. The character of major detection methods to detect SARS coronavirus in 2019. So major detection method is nucleic acid amplification test, and we called it NAT. So other than PCR method, antigen test. So we perform a quantitative antigen test. Could you hear it? So the major convenient detection method is rapid antigen testing. So it is used in worldwide. So the target, of course, NAT target is viral gene, and antigen test target is viral protein. So NAT is possible to detect lower viral load, but rapid antigen test is possible to detect high viral load. So assay time is different from these three methods. So NAT need 2 to 3, a couple of hours. So antigen test needs 30 minutes. So instrument, NAT and quantitative antigen test is necessary to detect by instrument, but rapid antigen test is unnecessary to use instrument. So I'd like to introduce a quantitative antigen test. So I'd like to show you the advantage of NAT built, so use test according as its characteristic. So I'd like to introduce quantitative antigen test. I think you see the many papers about NAT, PCR test, and rapid antigen test. However, many researchers understand but misunderstand. There are few clinical research about quantitative antigen test. Indeed, not small number of clinical research were done to date. So I'd like to introduce clinical research on quantitative antigen test. It's from Japan. So Yamanashi Central Hospital is near the Tokyo. So they use nasopharyngeal swab to detect SARS coronavirus 2. So they again report the additional number of nasopharyngeal swab to detect SARS coronavirus 2. It's from Toho University, Professor Tateda, and it's from National Center for Global Health and Medicine in Tokyo, Japan. So this kind of research is done not only Japan, but also Italy. This paper is from Italy. They use nasopharyngeal swab to detect SARS coronavirus 2. So that you can see the number of samples, 4266. So many numbers. They use quantitative antigen test, and they report the favorable result compared with not. So from Hokkaido University, they use the saliva sample to detect SARS coronavirus 2. So it's published in Lancet Microbe 2021. And then in addition, from Aichi Medical University, Professor Mikamo report the efficacy and validity of quantitative antigen test. So I'd like to introduce our achievement, Sapporo Medical University Hospital. So we manage the severe patients of COVID-19 and mild status of patient. So in advanced critical care and emergency center, we see 100 patients, and extra coronary ward, we see the 561 patients. So it's a number of examination of SARS coronavirus 2. So we checked so many number of SARS coronavirus 2 in our clinic. We have many instruments to detect SARS coronavirus 2. We can use real-time PCR. We can use rapid nucleic acid amplification test, and we can use quantitative antigen test. So many devices we can use, but now we use UpDirect 2019 Shimazu. It is real-time PCR reagent. So we use mostly like Tricra 480 or 196. And also we can use Gene Expert and Riot. So of course, we report some manuscript, and we use nasopharyngeal swab and saliva, of course. So a standard method is necessary when we use quantitative antigen test. So we use Shima's AMP Direct Kit as standard method of real-time PCR. The character of Shima's AMP Direct Kit is easy to extract RNA. This is the AMP Direct Kit. So we already published the paper about Shima's AMP Direct Kit. So the sensitivity and specificity is mostly equal to National Institute of Infectious Disease method and Roche real-time PCR kit. But now, our main detection method is quantitative antigen test. This is a machine. So this instrument called LumiPulse. So from the Fuji Revio, it's a major group of some laboratory medicine. So would you remember it? So Olympic and Paralympic Tokyo 2020 was held in 2021. So I was very impressive in some athlete and some great match. So it's the poster after the Tokyo 2020. So at Tokyo 2020, main SARS coronavirus 2 test instrument was LumiPulse L2400. It's the big quantitative antigen test instrument. So Tokyo 2020, we check SARS coronavirus 2 by using 13 instruments at the camp of the Olympic or Paralympic. In addition, quarantine stations at major airport in Japan. So they now use LumiPulse L2400, 12 instruments, and G1200, 40 instruments in Japan. So quantitative antigen tests do extremely well in this situation, in this corona era. So I'd like to introduce its advantage. So short turnaround time. Turnaround time means from received the sample and report. So we can, its assay time is 30 minutes and quantitative antigen test. It's similar to the rapid antigen test, but we need instrument in quantitative antigen test. But the advantage of short turnaround time is good for the report to the clinicians. So our policy is report of NET or quantitative antigen test. The report is the very day of the test. We surely report to the clinician at the very day of the test. speedy test means negative result within 30 to 60 minutes, we can report it. In addition, prompt management is possible for COVID-19 patients, so positive SARS coronavirus 2 patients. And second, the advantage of quantitative antigen test is maximum volume of sample management. So you can see the character of each instrument. Each number of instrument is lumipulse. It's a quantitative antigen test instrument. So G600 assay time is 30 minutes, and the capacity was 60 samples by hour. G1200, its assay time is 30 minutes, and its capacity is 120 samples an hour. And we use instrumented. So L2400, its assay time is 25 minutes and 240 samples by hour. So this kind of instrument have enough capacity and to examine so many samples. It's the advantage for laboratory practice, clinical real-time, clinical real-life laboratory practice. Therefore, we can check such a so many specimens in Sapporo or Hokkaido prefecture. So we can contribute to some hospital or some administrative samples from some clinic or some long-time care facilities. So I'd like to emphasize the special advantage of quantitative antigen test. So the situation with quantitative antigen test was negative and real-time PCR test was positive. This is a famous schema to viral load and PCR status. And this means a rapid antigen test sensitivity. So onset of the infection and the viral load is increasing, and then viral load is decreasing. So this is a status of post-infectious positive by PCR, only by positive by PCR. So our data shows the quantitative antigen test is like this. We can detect SARS coronavirus 2 the degree of viral load is CT value 38 of real-time PCR. But this status, post-infectious positive by PCR, this quantitative antigen test judge negative this status, however positive by PCR. Yes, This group was short time after onset, days after onset. So they also positive by PCR and positive by antigen test, quantitative antigen test. However, long time after onset, this group is a long time after onset. So positive by PCR test and negative by quantitative antigen test. So we check the antibody in these patients. So positive by PCR test, but negative by quantitative antigen test. So the result was mostly positive antibody in these patients. Therefore, I understand the character of quantitative antigen test. It's a short time from onset. It's a similar result to PCR. However, long time after onset, it's a different result from PCR test. It's very interesting character in quantitative antigen test. So this is a flowchart in clinical laboratory in our hospital. This is another pharyngeal swabs flowchart. So it's very complex, some complex schema, but the less than 1 picogram per ml, it means a negative, and 100, more than 100 picogram per ml, positive. But from 1 to 100, we can do recentrifuge, or we retest by PCR. We believe this method is to get the precise result by this quantitative antigen test. So in saliva sample, it's more complex. So we can twice centrifuge pre-assay, and less than 0.5 and more than 0.5. Because saliva sample is some complex component, or some mushiness or sticky character compared with nasopharyngeal swab. So it need to level down by this point to distinguish a negative or positive. At the laboratory, clinical laboratory, so we need to support by PCR instrument. Because we need a retest by PCR in some degree of antigen value. So if we have enough time to test, we used AMP Direct in 2019 Shimazu. But we have time to tight, so we use Gene Expert or Riot. So we have 6 Riots and 16 box Gene Expert. And we again emphasize the complexity of saliva sample. The single time on centrifuge is not appropriate. So we can use twice centrifuge. Twice centrifuge is necessary to remove mucinous ingredient or sticky adhesive. When we perform twice centrifuge, the value was not different from the statistically difference. But indeed, we need another 10 minutes to start assay if you use a saliva sample. So it's a very favorable because we do not have PPE to get this sample. But in the point of view from laboratory medicine, we need another time, another 10 minutes to start assay. So it's good or bad. I'm not sure about the issue of this 10 minutes, but I do not like another time to start assay. So at last, I'd like to tell you the management of variant strain. So quantitative antigen test target is N protein, nucleoside protein. So not spike protein. So this test is not does not affect the detection of S gene variation. Okay, from the report from Italy, they confirm no, not affect the detection if the original strain and alpha strain. So yes, I hope to conclude my talk. So quantitative antigen test, the character of this test is rapid detection and manage high volume of samples, and of course, high performance. In addition, its perform is precise judgment in clinically cure status. However, it needs to support by PCR, but it's not so big problem. Quantitative antigen test is a very, very good job in Japan. So I'm very happy to introduce this great test of method. Thank you very much.
Okay, thank you very much for the nice lecture, Professor Takahashi. And I'd like to check the question here.
Okay.
Okay, there is no question from the remote. So I have one question. In your lecture, I understand quantitative antigen test is attractive, but I'd like to know the cost of the test. Do you think it is good for the about big hospital or small hospital anywhere? So please explain about this.
Okay. Thank you, Professor Matsumoto. So it is better to use a big hospital, not a clinic or small hospital, because the cost of instrument is expensive, honestly. But like our hospital, we can manage so many samples in hospital or carry-on samples. So we can use this big instrument, but the small hospital or clinic, they should use some small instrument or some rapid nucleic acid amplification test and gene expert or LIAT is better, I think. Thank you very much.
Okay, thank you very much. Okay, so it's time for the next speaker. Thank you very much, Professor Takahashi.
Thank you.
Okay, so the next speaker, I'd like to introduce Professor Kunishima, Hiroyuki Kunishima. He's a professor of Saint Mariana University School of Medicine, Department of Infectious Diseases. Of course, he is the expert of the COVID-19 and also infection control and other many fields. So the title of his talk is Treatment for COVID-19. So please start the lecture, Professor Kunishima. Professor Kunishima?
I'm sorry.
Okay. Yes, please.
It's okay. Hear me?
Yes, I can hear you.
Thank you for your introduction. First of all, I would like to express my sincere appreciation to give the chance to talk about the situation of COVID-19 in Japan. I'm Hiroyuki Kunishima from Department of Infectious Disease at St. Mary's University School of Medicine. In Japan, medical treatment for COVID-19 began in February last year from the cluster found on a cruise ship in Kanagawa Prefecture. A total of 5 waves have been seen. The largest number of COVID-19 cases was seen in the 5th wave from July to September this year. And there were many cases where hospitalization was difficult. In 2020, there were many deaths of the elderly person. Vaccination began in spring this year. Since the summer, there have been more cases among unvaccinated younger people. Now about 80% of the population have been vaccinated at least once. At this moment, November this year, the 5th wave look almost end in Japan. In addition, the 3rd dosing of the vaccine is scheduled to start early next year. Japanese population is nearly 120 million and about 1.7 million people have been infected with COVID-19. And about 80,000 have died from 2020 until now. So the mortality rate is about 1%. COVID-19 have a wide range of symptoms, from mild to severe. Elderly people and high-risk population are more likely to have severe symptoms, while younger people are more likely to be asymptomatic or have mild symptoms. Therefore, it is important to consider the risk factor for severe disease and provide appropriate medical care. Currently in Japan, in principle, all patients are either hospitalized or should stay at recovery accommodations as designated hotel for the positive case of COVID-19. When a patient diagnosed with COVID-19, the physician will report the severity of the patient illness and risk of severity to the public health center. Then, physician, public health center, and local government agency will determine if the patient needs to be hospitalized. In case of mild symptoms with lower risk of severity, at growing phase which limited hospitalization, the cases should be treated or less at home. Even if patients stay at home, SpO2 is also monitored at home, and public health nurses will contact patients regularly to check the health status. The treatment will be terminated after 10 days from the onset and 72 hours after the improvement of symptoms. There are no extra charges for the treatment. This is accommodation medical treatments such as a business hotel. Basically, it is private room with toilet and shower, and 3 meals a day will be served. There are nurses on duty at the hotel 24 hours a day, so the patient can consult with them if they feel unwell. This is a hospital room for moderate cases. Patients with pneumonia who require oxygen treatment but not need mechanical ventilation are admitted here. In the back is ventilation system with HEPA filter. Currently, the number of airborne infections like tuberculosis is decreasing in Japan, so not many hospitals have the kind of equipment. For the treatment, patients are mainly receiving antiviral drug or steroids. We have around 340,000 dialysis patients here in Japan. Dialysis patients with COVID-19 are high-risk group for the severe illness. And so they are usually using private room for dialysis. This is a photo of ICU of St. Maria University School of Medicine Hospital. Ventilator management, or ECMO, require a large number of medical personnel, and ECMO management can only be performed by a limited number of medical facilities. In the fifth wave in the summer of this year, all of our ICU became COVID-19 beds, and regularly medical care was greatly restricted. This is a flowchart of Kanagawa Prefecture. Regional cooperation is important for the effective medical care at limited conditions. Upon diagnosis with COVID-19, patients with mild symptoms are admitted to home or accommodation treatment, and patients with moderate are admitted to priority medical facilities, and then severe cases admitted to advanced medical facilities. If mild or moderate patients become severely ill during the course, they will be admitted to appropriate medical facility, respectively. Medical facility will be provided with advice on infection control and supply any of medical support. The different medical treatment of COVID-19 is needed at the timing of onset. Antiviral drugs are used in the early stage of onset, and for the later stage, immunosuppressive therapy is used for a cytokine storm. So it is important to carefully assess the patient condition or phase of illness. It's quite important to determine the patient's severity for COVID-19 treatment. It's well reported that the depression in lymphocyte and higher level of CRP, procalcitonin, and D-dimer. Among our hospitalized patients, many patients with pneumonia had decreased lymphocyte, and their lymphocyte recovers as they improved. Therefore, decision of the diagnosis item may be dependent on the patient, medical phase, and source. Further research might be needed to standardize. This is an example of treatment in Japanese hospital. No oxygen supplemented patient, but has risk of severity, usually treated by neutralizing antibody. Remdesivir and dexamethasone are given for patients with pneumonia, with requiring oxygen. Tocilizumab and baricitinib may be considered for those requiring mechanical ventilation. Currently, 3 antiviral and immunomodulators drugs are approved for the treatment of COVID-19 in Japan. Remdesivir as an antiviral drug and corticosteroid and baricitinib as immunomodulators. Favipiravir can be used after filing an application with the authority. Clinical trials are underway for ivermectin, favipiravir, and camostat. This is a list of Japanese treatment in last year at Tokyo. Favipiravir was given to the largest number of patients, followed by the inhaled corticosteroid secresonidone. Remdesivir was approved in May 2020, and the number of patients receiving it is increasing. In this year, antivirals, immunomodulator, and neutralizing antibody therapy are being administered. SARS coronavirus 2 adhere and invade source is angiotensin converting enzyme 2 and then mature. Antiviral drug blocks multiple process of viral infection and then inhibit the infection. Remdesivir is an RNA polymerase inhibitor originally developed for Ebola hemorrhagic fever. Previously reported that remdesivir may be effective on the non-severe supplemental oxygen therapy COVID-19 patients. Remdesivir should be carefully administered with renal dysfunction. The efficacy of remdesivir seems to be controversial, but previous study shows that treatment for earlier phase before required oxygen showed higher effectiveness. Favipiravir is an RNA polymerase inhibitor originally developed in Japan as a drug for influenza. Previously reported that favipiravir has antiviral activity against SARS coronavirus 2, both in vitro and vivo. Report from Russia, the result of placebo-controlled RCT shows significant effect on the clearance of virus and a shorter duration of normalization of temperature. However, initial open-label RCT conducted in Japan could not show significant results, probably due to the limited number of patients. Afterwards, a single-blind RCT was also conducted in Japan, and I would like to introduce the result as this slide include patients with COVID-19 pneumonia without oxygen administration. The primary endpoint was improvement of body temperature, oxygen saturation level, and finding on chest imaging, and also duration of clearance of SARS coronavirus 2. The median was 11.9 days in the Favipiravir group and 14.7 days in the placebo group. The adjusted hazard ratio was 1.593 with a statistically significant difference. Furthermore, significant improvement in symptoms was observed when administered within 5 days of onset. It is important to start antiviral medication early in the course of the disease. Significant improvement was also seen in patients with BMI over 30 and high CRP levels. Favipiravir is considered effective in non-severe COVID-19 patients. Currently, additional clinical trials are ongoing in Japan. Notably, preclinical data show tetragonality and thus need to careful guidance. COVID-19 is one of rare infection that could be treated by steroids. In COVID-19 cases with requiring oxygen patients, steroid can reduce mortality. On the other hand, increase of mortality rate were reported in the patient without required oxygen. Therefore, steroids should not be given in mild cases. Ventilator management and ECMO are used for the severe cases. In addition, severe cases also administered with IL-6 inhibitor to avoid cytokine storm. In severe cases, patients receiving steroids or immunomodulator become immunodeficiency condition and with higher risk of sepsis. In our hospital, we find more than 20% of ECMO patients suffered bacteremia. So for the severe cases with long-term treatment, measurement of many complications should be needed. From outside Japan, many cases of pulmonary aspergillosis associated with COVID-19 were reported, but not so many in Japan. Differences of approval immunomodulators between Japan and other countries might be one of a background of these differences. Neutralized antibody bind to the spike protein and then inhibit to the invasion of virus into the host cells, such as neutralized antibody therapy. In Japan, neutral antibody therapy for SARS coronavirus 2 was approved in July this year. Casirivimab, imdevimab, and sotorivimab. Casirivimab, imdevimab is expected to reduce hospitalization and mortality when administered to high-risk patients. In Japan, it is requested to be administered as soon as possible, up to 7 days after onset. In any case, the best would be to start administration immediately after onset. Age, underlying disease, and BMI, body mass index, are important inclusion criteria for the clinical trial. Non-required oxygen cases can be treated with this drug because high-dose oxygen treats the patients show the progression of disease. Side effects seems to be rare, such as anaphylactic shock. 3 months after treatment with this drug cannot allow since the antibody titer stabilize until 3 months. Currently, clinical trials are being conducted on many therapeutic agents for COVID-19. Among them, there are many basic and clinical studies on neutralized antibody drugs and antiviral drugs. This respiratory tract is a main target site of the virus. Some inhaled strains have been reported to have antiviral activity. Among them, clinical study results showed antiviral activity of secresonidone. In addition, more improvement was seen in the RCT of the budesonide group. Further studies are expected in the future as to what kind of patient it is effective for. Ivermectin is a drug discovered by Professor Omura, a Nobel Prize. Originally, it is an anti-amyloid drug for scabies and onchocerciasis. Ivermectin has been reported to have antiviral activity against SARS coronavirus 2, and the clinical trial was started. Molnupiravir, an RNA polymerase inhibitor that effective to the hepatitis C or influenza virus and promising drug in the future. As you know, this has just approved in UK. This is an orally administered form. Molnupiravir is expected to reduce the risk of hospitalization when administered during early onset. An interim analysis of clinical trial was announced in October this year. Molnupiravir is expected to lead to future outpatient treatment of COVID-19. Shionogi is a pharmaceutical company that has previously developed antiviral and antibacterial drugs such as dolutegravir and baloxavir. Currently under development is S217622 that has antiviral activity to SARS coronavirus 2 by inhibit proteases. This drug targets 3CL proteases of SARS coronavirus 2. Currently, there is concern about attenuation of antiviral activity of most commonly used antibody drugs due to the mutation of spike protein. This drug is expected to be highly safe and does not reduce susceptibility due to the mutation in spike protein. This slide shows highly antiviral activity against conventional strains, alpha and delta type variants. In mice, SARS coronavirus to decrease with dose-dependent manner. Phase 2 and 3 will be conducted in this year, and then clinical available in next year. Prophylaxis is one of an option. Traditionally, influenza and HIV have been post-exposure prophylaxis. Currently, the effectiveness of post-exposure prophylaxis with neutralizing antibody has been reported for COVID-19. It's known that amount of virus is increasing before onset of symptoms, and so prophylaxis might be effective to COVID-19. COVID-19 is known to have long COVID, like fatigue, headache, and taste of smell disorders. Currently, traditional herbal medicine is considered to be used in Japan. Also, sequelae is thought to be affected by inflammatory cytokines, but specific evaluation methods are not yet established. Further research is expected. Currently, the global probiotics market is expanding. Probiotics are widely used in Japan for cross-regional difficile infections. Recent studies have shown that one of the benefits of probiotics is its anti-inflammatory properties. It has been suggested that COVID-19 is also related to gut microbe, and it is expected that probiotics will be used. There are currently many clinical trials of probiotics for COVID-19. For example, in a clinical trial for long COVID, it has been reported that there was a significant improvement compared to the placebo group. Currently, it is expected that vaccination will reduce the severity of the disease and that oral treatment will be introduced, which will help shift from inpatient care to outpatient care. As you can see, we are strongly pushing to have vaccination and enhancement of outpatient clinical operation for mild cases. COVID-19 cases will continue throughout the region. It is extremely important to continue sharing information in the region. Crisis management of COVID-19 in the entire region will be required.
Professor Kunishima?
Yeah.
We have only 1 minute, okay?
Yeah. This is last slide. It has been about 2 years since COVID-19 global pandemic. In 2020, even by using masks, social distance, and hand hygiene, many people were infected and died. So next year, 2022, we might be getting new and more technique for infection control and treatment. Thank you for your attention.
Thank you very much, Professor Kunishima. Unfortunately, we'd like to close this session, and thank you very much for everybody for attending this session. So we'd like to close. Thank you very much.
Thank you very much.